And today is June, what, 30th? 30th. Just around the corner is July 4th, national holiday, celebrating America's independence. But today, we're going to be performing a Deuk Laser Disc Repair. Our first case is a patient who has 3 thoracic disc herniations and thoracic pain. This patient has tried everything, and he's awake with us right now in the operating room. Good morning. It's Dr. Deukmedjian. It's real important you keep your head down and lay still. Do not move your body throughout the surgery. All right? I'll be asking you questions from time to time. If you can't hear it, the anesthesiologist will repeat it, okay? 90% of my conversation will be with the team or our viewers. So just lay still, don't move. If you have pain, say ouch, just like we did last time. All right. So our patient has tried everything for his thoracic disc herniations, from therapy to injections, rhizotomies, stem cells, everything except for surgery on the discs, which we know will work, but it's in an area of the spine that's very difficult to get to. So I told him no promises, but we're going to try it. We've done thoracic herniations before successfully and eliminated the pain from a thoracic disc herniation. It's just that sometimes you really have to convince yourself that the thoracic disc herniation is the cause of the pain, because usually it's not. All right, let's get an x-ray. All right, so you can see that we're pretty close to the pedicle of T12, just above it, where the last rib is. And then, so let's do that again, shot. All right, so I'm right at the disc space. It looks like T11-12, because T12 has a rib, and then the one below that doesn't, which is L1. Let's see if you can give me, and I probably will have to do 2 incisions. So I'm going to give you some numbing medicine, okay? You'll feel a little stick and burn. That's normal. Don't freak out. This is perfectly normal, okay? Don't get upset. I'm sorry it's going to burn a little bit. That's just the numbing medicine going in. So I like our blood pressure systolic to be around 100. No more than 110, no less than, say, 80. But anywhere between 90 and 100 will be perfect. Okay. Now, normally we wouldn't be doing surgery on a thoracic disc herniation unless it was the last resort for eliminating pain. And our patient, unfortunately, has had severe pain since a motor vehicle accident. And we've tried everything that we can do except for surgery. And we talked about a fusion surgery versus laser. So we got to get our blood pressure down a bit. Yep, take your time. I'm just going to wait until we get that down. So obviously in the beginning of these surgeries with the patient awake, blood pressure control, and then anxiety, pain control as I'm starting the surgery. I do some local injection, but it's never enough. Patients always need a little more than some local. All right, are you comfortable? All right. Local. Do you still feel anything there, or is it more numb? A little bit? Okay, all right. Well, we got time. We're just working on numbing you up for right now. Shot. let's go lateral. So the thoracics are the hardest to do. I haven't done many of them. This would be my third patient with a thoracic disc herniation. All right, he knows that. I told him that before. He's aware. But he wanted still to try it and see if we could fix his problem. All right, so that's the best lateral we have. Now, can you take a deep breath for a second and hold it for 3 seconds? Tell me when you're ready. All right, take a deep breath and hold. 1, 2, take a picture. 3, all right, now go ahead and release the air and hold your breath out. Go ahead. Breathe out and hold it out. 1, 2, so that's breathing out. All right, good. You can breathe normally. Patient's awake, and we're going to keep it that way for most of the surgery in the beginning, and then once we get to where we need to be, we can put him to sleep. Are you feeling any discomfort? A little bit? All right. So remember, if it bothers you a lot, you say ouch, okay? Shot. All right. Let's get an AP. So now let's get a true AP, look down the disc and see where we are. I don't mind you being a little off to my side. I just want you to rotate it though till we get a little better AP view. It's not horrible, but I'm not looking down the disc. Shot. All right. That's not bad. All right, looks like we're heading towards 11-12. And let's go back to a lateral view. 11-12 is the middle disc that we're doing. Go ahead. All right. Shot. What do you have there? Give me an AP. All right. Let's go back to a lateral. Shot. Where was the last shot? Over there? Shot. Shot. Are you comfortable? All right, so the pedicles are not really lined up the way I want them at the pedicle above the needle tip. The one below looks okay, but maybe just about a degree or two of wag, and let's see if we can improve it. Doesn't need a lot, just a little bit. I think that's better. Let's keep that. Shot? I'm on the facade. So that's good. Just need to redirect. Shot? You okay? Shot? You're doing fine. Let's see if we can make him a little more comfortable. Shot. AP. Shot. Yeah, we're right on the facet. Lateral. Just let me know what you're giving. That's where we are. All right. Let's see if we can do this, rotate this. Maybe your side down a little bit. Let's get the diaphragm. That's better. Shot. 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 Try to relax. Everything's okay. Shot. Where do you feel that, Sean? Huh? Just repeat what he says because I can't hear him. Sean?
Where did you feel the pain?
Yeah? Where do you feel it, sir? Sean? Sean? Shot. All right. AP. So we're around the facet. All right, that's looking good. That's a nice AP. It's looking good. Lateral. Just try to relax. You're doing great. Where do you feel it? Repeat what he said. Just lay still, please. What did he say? In your back? All right. Yeah. Shot? Well, we know this is one of his herniations, so. Shot? Shot? All right, let's give it an AP. You breathing okay? Sats are good. All right, perfect. All right. Yep, So we got T11, 12. We've got to do now one above, one below. So let's go back to the lateral view. This is going to be different today. I have to see what we've got. Is it better now? All right. Sorry it's so uncomfortable for you. All right, so we got one above and one below we've got to do. For sure, one below is going to be a different entry point. So we're going to have to go further south, which we're prepared for. Where do you feel that? Huh? Where does he feel it?
Where do you feel it? Where?
In your back? All right. All right. Well, that's okay. All right, let's see if we can line up the bottom disc, which would be, should be 12-1. Let's see if we can line that up better. I think we're off just a little more. Get a better view. Maybe it was just because he was inhaling. Let's try another shot. You're doing great. Everything's going well. I just need you to help us cooperate. Take another shot. You're doing really good. Just lay still and try not to move. Okay? You're doing good.
Yes. It's okay. I'm just helping you with the pain.
Shot.
Medication might make you feel a little different, okay? That's
Shot.
the whole way.
Shot. Shot. You mean AP? All right, and my lateral is there. Yep. All right, let's go back to a lateral view. We should be hitting the facet pretty soon. There it is. Just lay still. You're doing great. We're about halfway done. And then I'm going to put you to sleep, okay? I'm just thinking they may want to start a little bit lower. I think we're seeing too much of the back. Maybe you can drop the fluoro a little bit. It's as low as possible. Can we get the blood pressure down? Yeah. You okay? Well, I just need you to lay still and stay calm and you'll do fine. You're making history here. I know that's not reassuring, but we've told you that before. And I know you know that I've not done 3 thoracics before, but everything is going well. I told you we'd do it as long as things are safe and going well, okay? All right. So we need to do something. I mean, it's not terrible, but I feel like we're rotated a little bit somehow. It's not much, so I don't want to lose what we've got, but let's see what you can do. Shot. I wonder if that's worse. I don't know. I can't really tell because it did change. It's not horrible. Let's try something and see if it makes it better. But that's actually not bad. So what we're doing, folks who are watching, is we're trying to line. I think that's probably worse, maybe a little bit. We're trying to line the. We have to be able to see. I'm navigating. I'm going from the outside world down to the spine. That's better. Let's leave it there. And to do that, I have to see the spine. And you can't see the spine through the skin with your eyes. You have to use a special technique using an X-ray. Okay? X-ray is the best way to see the spine. Shot? But X-ray has limitations, okay? You can't see soft tissues. Shot? So it's a compromise between seeing the bony spine, but not really seeing the soft tissues. But you know what soft tissues are there because in the areas where there's not bone, there's soft tissue. So you use not just the view of the bones, but also the absence of bones, and so, to know where the soft tissues are. So if that makes sense. All right. Let's see where we are here. Coming up on the facet joint. Trajectory looks good on the AP view or lateral view. Shot. Shot. And I know it's hard for the audience to appreciate what's happening here. Give me an AP. But there are literally movements that are less than a millimeter I'm doing with the needle to navigate around hard bony structures and soft tissue structures that I'm not really talking about because I need all my attention to do it. Yeah. Come back. Rotate it a little bit because you're off center. All right, let's get the lamina between the eyes. You're still rotated for some reason. That's definitely better. So the question is, go back to a lateral view. Huh?
Yes, sir.
Are you uncomfortable? Yeah. No, he's, from my standpoint, I'm happy with where we are.
Okay.
Shot. All right, let me see if I can give him a little bit more local. That's where we are right there? Okay. So we're in the soft tissue, which is good. Shot. We need this light off here. It's kind of right in my eye. I don't know why we have that on in the first place. I gave you some more numbing medicine. Hopefully that's helping you, Sean. Again, our trajectory looks promising. Shot. AP. Are you uncomfortable? Huh?
Yeah, I told you you're gonna feel a little weird. I knew you were gonna.
Okay. I'm not opposed to that. That's the facet. Shot. Let's go lateral. I think we're in a good trajectory. As long as we line up on the lateral, the AP looks good. This is 12-1, you can see. Shot. Let me know if you feel any discomfort. Shot. Is he awake?
Yeah, he's alright.
AP. Huh? Are you comfortable?
Let us know when you have pain.
We're right there. I think that's looking good. Let's go back to a lateral view. You have any discomfort? Is he reliable right now?
Johnny, do you have any discomfort?
What's he saying?
A little scared. A little scared.
Scared? But is he having pain or any discomfort?
Because when he has it, he says it hurts. It hurts.
Shot. Shot.
No, just be honest. If it hurts, let us know, okay?
Yeah, I'm right at one of his bad discs. Shot. I'm going to be a little bit higher than I am though. Shot. Shot. Yeah. Hitting the end plate. Shot. Are you okay? Shot. That looks. Shot. Shot. Yeah, we're right there, but we're not close enough. Shot. 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 Yeah, we're right there. You're doing great. We're there. Shot. We made it. All right, you doing okay? All right, we're 2/3 of the way done with you being awake. We have, let's get an AP. I want him a little bit more alert.
Okay.
Are you feeling any pain or anything? Huh? No? Good. That's good. All right. Yeah. Shot? Okay. All right. So, I don't see a rib below. That's got to be 12-1, and then 11-12, and then 10-11 would be the last one. So, looks like I'm going to have to do 3 separate sites. I don't want to take any chances. Let's go back to a lateral and get up a little higher. Is this my local? Let's go to a lateral, please. So we're gonna definitely have to make, I mean 99% we're gonna have to make 3 separate incisions, which is fine. You're tiny anyway, but I'm not able to do all 3 from the same incision. You don't care, right? Huh? As long as we fix your back, you'll be happy, even if it's 3 tiny little incisions. So I need the table down a little bit, and can we zoom in at the disc above? At the disc above, that's the important one. The last one, yeah, that's pretty good. Now, let's try, our ribs are not lining up perfectly. Let's try some of this. Probably, maybe bring my side higher. I don't know. Let's see what that does. Shot. That's definitely better. Now let's try a little bit of, I mean, it's not bad. Maybe try a little wag. I think it's going to make it worse, but let's try a little wag and see what happens. Are you okay? All right. I think that's better. Let's try to bring the ribs. They're not bad. Not bad. The patient definitely has scoliosis. They have some scoliosis, so that's going to be an issue. I mean, not an issue in terms of pain after surgery, but it's going to be an issue in terms of me being able to visualize, you know, the spine with proper alignment. Let's see where we are. All right. So, if anything, we need to aim. Shot. Is that uncomfortable? All right. Well, I want to make this as comfortable as possible for you. So, shot. Shot. All right, I'll give you a little bit more numbing medicine, okay? Where'd you feel that? What'd he say?
What part of your back did you feel that?
Shot.
Wherever you're doing.
In your back, right? Sir, in your back?
Yes.
We're not anywhere other than the fascia. We're not far enough to be anywhere near the important stuff just yet. Shot. All right, it's not bad. Shot. Where do you feel that? Shot. AP. All right. Yeah, I need him awake for this last part, and then we're gonna be able to put him to sleep soon. Yeah, yeah. All right, so it's okay. You're fine. Remember, we're here to help you. Shot. Let's go lateral. So we're heading to the last facet joint on the left side, and I like to dock the tip of the needle on the facet joint and then work my way just lateral to the facet joint. I think that's the safest way to do it. I've been doing that for years. It's one of my secrets to my technique, and it works nicely. And if you're at the facet joint, you know you're going to be in a safe place. Shot. Where do you feel that? You feel it in your back? Where does he feel it?
Feel it in your back?
All right. How's your breathing? Any shortness of breath? What do you say? All right, we're almost done, I promise you. This is the worst part. And we're almost done. That's the good news. Almost done, my friend. Shot. Help me out here. You're doing fine, Shot. Shot. The trajectory looks good, but I have the facet joint here I'm contending with, and I'm unable to redirect. Shot. Don't tighten up, you're doing great. Just help me out a little bit more. Shot. Yeah, you're doing great. Shot. Again, trajectory looks good. Lung fields look fine. Shot. Shot. Where do you feel that? Shot. Where do you feel that? Can't understand him, Shot.
Say whatever you're doing, it hurts.
Okay, all right, understood. It hurts in your back. Shot. Is that better? Where do you feel it? Where do you feel it? Where does he say? Oh, okay, got it. Yeah, all right. It's in your back, right? Shot. Yeah, you can say your back. That's fine. We're almost done. Shot. Shot. You're doing great. Shot. All right. Anything in your legs? All right. You're all done. We're where we need to be. You did it. You just, all right. So I've done the most uncomfortable part for him. And now we'll test. And then we'll be able to put him to sleep. I just need him to be reliable when we test. Are you comfortable? His lung fields look pretty good. I don't see any problems there. Take a shot. Give me an AP. Let's just make sure we're where we need to be. Perfect. Absolutely perfect. All right. Lungs look good. You agree, doctor? You guys see his? Yeah. All right. So, are you comfortable? Either one, whatever is better for you. Are you having any pain? No?
Are you having any pain right now?
All right. Is it better? What? You feel something there? Is that where you typically get your pain? How bad is that on a scale of 1 to 10? 10? All right. T10-L1 is a 10. And it's concordant. It doesn't take much dye. Is that better?
Is that better?
All right. What do you feel something there? How bad is that on a scale of 1 to 10? All right, 10. Is that where you typically get your pain? Concordant. So for those of you watching, the patient and I are having a conversation. I'm actually testing the discs, the 3 discs that we're about to repair. Just want to make sure they're actually causing his pain. How bad is that? Scale of 1 to 10. 10. Is that where you typically get your pain?
In that area, yes, sir.
And that was T10-L1. All right. Well, when you wake up, we'll be done. You did it, and hopefully everything else will go smooth. We were able to get what? We're able to get access to all 3 discs. All right. So you get to go to sleep now, and when you wake up, we'll be done. All right. So we're going to start with the T10-L1, and let's just get one more X-ray AP, or can you show me your AP? That's it. I want a zoomed out AP just to make sure we're in the right spots. I can see he's got tears in the back of the disc. You can see the herniations are outlined. If you look at the middle needle on the lateral X-ray, I don't know if you have a lateral X-ray sunny up, but you can actually see the bulging disc right there as the needle comes into the spinal canal. You can see the outline of the herniation. There's 2 of them. It looks like, well, the one that we're treating is the big one, and that looks like it's bulging backwards. All right, I need to see a little bit further south. I want to make sure we're at 12-1 at the bottom. So try to give me a better AP, like this way, a true AP. So to me, I can see the rib coming in at the T12 pedicle. I can see the T10-L1 transverse process. Just lay still. So come over to my side a little bit. Come over this way. Just move the whole fluoro to my side. Take a shot. You're supposed to be zoomed out more, but I don't know why you're not zooming out more. Shot. Yeah, so that's T12L1. You can see the T12 rib going in, the L1 transverse process. Yeah, it's time to go to sleep. All right, let's go back to a lateral view, please. Lay still. Don't move. You're going to go to sleep now. Start counting from 1 to 100 out loud. Count from 1 to 100 out loud. Out loud, starting at 1. Breathe however you're comfortable breathing, sir. Start counting. All right. We don't need to see the back as much as we need to see the disc. So maybe lower the raise the bed or lower the fluoro. All right. Let's see where we are there. Shot. Shot. Why do we just lose our picture quality? What'd you do different?
I think it's just great.
Shot? Nah. Let's drop the table a smidgen. We're underexposed. That's the problem. I hope you can tell that. That's fine. Let's just leave it there. All right. Shot. So I want to make sure my guide wire is deployed. Shot. Shot. Give me an AP, please. Yeah, there's the guide wire. Shot. Shot. All right. We need to change the rotation on this because you're way off. Jordan, you got to be able to do this stuff. Some of this stuff is basic. You should be able to do it yourself. See the ribs, how they're not lined up? See how one side is higher than the other? So try to get the ribs lined up better. I think it's the other way. Go ahead, take a shot. Yeah, it's the other way. I don't know if you can tell this side is higher. That's better. Shot. All right, that's good. Okie dokie. How's he doing? Is he asleep? Stable? Stable?
Yeah, it's stable. Pressure
Good.
117.
So for this surgery, we don't do the 7mm incision. Try to bring the pressure down a little bit. We do the 4mm incision because we're using the cervical scope. The cervical scope is for the cervical spine and thoracic spine. It's a smaller diameter shot. It's a smaller diameter scope. Now we already know the pathway we've selected is a safe pathway. At least we're 99% sure of that. So now we're bringing our instruments in, like our dilator shot. And this will go right to the back of the disc. Shot. Shot. Let's get an AP. Remember to come back to that lateral position. Okay. Shot. That's beautiful. Absolutely perfect. Let's go back lateral. Our patient's asleep at this point. Shot. 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 All right. Shot. 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 Looks good. Take. So, fluid adapter. Thanks. So these camera stuff, endoscopic cable should go above the suction line. Okay.
Probably want to fight a little bit.
No,
No?
no, we're ready. We're going to switch to our endoscopic view. Now we have a channel, a way to get down to the disc that's herniated. Watch the fiber with my face, please. And we're going to go in and basically do the Deuk Laser Disc Repair procedure, which is where I would go in and remove the herniation with a laser. Remember, we're working in a very small space. There's not a lot of room. So there's two different types of systems that I use. One is the cervical, the other is the lumbar. And the actual endoscopes are different. One is a 4mm endoscope, and the other one is a 7mm endoscope. So we're using the cervical for the thoracic region. Why? Because the thoracic discs and anatomy is more consistent with cervical, meaning there's small space to work. And so I'm using a cervical system with the thoracic. You can see the bone right there to the right. It's now at 12 o'clock. That's the little bit of bone spurs, and there's the herniation right there, a piece of it. Pretty scarred up. I'm going to be twisting this quite a bit. We have any questions from our audience, Sonny?
Nothing as of yet.
All right, if you're watching the surgery today, or any day, you can actually ask questions. If you're asking questions today, they'll be answered live during surgery. Okay? So, you're welcome to ask me questions. If I can answer them, I'll answer them. If I can't, I won't.
One question just came in.
Perfect.
It's actually from Sue. She thanks you for the cervical
Oh,
TLDR.
Sue Griffin.
Yeah. She's asking, do you do many thoracic?
No. So the question from our viewer, Sue, from England, by the way, who, if you don't mind me saying, Sue, flew out here to Florida and had the laser surgery done. She's asking, do you do many thoracic cases? The answer is no. Very rare. As a matter of fact, this is only my third one in my entire, 14 years of doing these laser surgeries. And the reason is simple. There's very few people that have thoracic disc injuries. It is not a common problem. It's rare. It's rare to have a symptomatic thoracic disc herniation or injury. Very few people have thoracic pain, and when they do have thoracic pain, it's most commonly coming from the facet joints. That's the FACET joints behind the disc, not the disc itself. Why am I getting water down on my feet? So it's very unusual to have a painful thoracic disc herniation. And this patient so this patient was in an accident, a car accident, a very bad accident where he injured his neck, his lower back, and his thoracic spine. And when I first saw him, he was complaining of neck pain, back pain, lower back pain, and thoracic pain. And so he tried conservative treatment with therapy, shots, etc., the usual stuff, medications, time, giving his spine a chance to heal. So he had spine pain in the neck, the lower back, and the thoracic, the middle part of the back. We did imaging. We saw on an MRI that he had herniations in the cervical, herniations in the lumbar, herniations in the thoracic. And of course, we treated him with time, see if they'll heal on their own and stop hurting on their own before we did any kind of surgery. And we tried medications, muscle relaxers, narcotics, anti-inflammatories. We tried behavioral modification, activity restrictions, etc. And of course, he continued to have pain. And I say, of course, because he ended up having surgery on his herniations in his neck. He ended up having surgery on the lower back herniations. And the results were so good. He was so happy and pleased that the pain was completely gone in his neck and his lower back from my laser surgery that he said, could you do it in the thoracic? And I said, no, I don't do thoracic herniations. It's much more complicated. It's much more dangerous. It's riskier. It's not, it's not really your top choice of treatment. So we tried epidurals in the thoracic spine. We tried facet, medial branch block. I think we even did rhizotomies. And we did even stem cells. He did stem cell treatment, which is a newer treatment that we offer at Duke Spine. And they didn't work. And so, not in his case. And he had these herniated discs on MRI and basically kept coming back and telling me how wonderful he was with his neck and his lower back, but how miserable he was with his thoracic. And after we had tried everything, medication, therapy, rhizotomies, epidurals, stem cells, PRP, we did everything we could. There was the only one thing left, and that was surgery. And I knew that if I could get in and get to those discs with the needles, which we just did, that I could fix his pain in his discs from his herniations. And I didn't want to promise him anything, and I told him, look, I've never done a 3-level thoracic ever before. I've only done 2 1-levels. And of course, he's been treating with us for several years. So when I first saw him and I saw the thoracic herniations, I told him no on the laser. But then in the last year, I've done 2 thoracics, and they both were very successful. Both patients had 100% pain relief on the thoracic spine. So I was very encouraged. And actually, the surgeries went very smoothly, very well. I didn't have any problems. I was worried about the lungs. I was worried about the spinal cord. I was worried about blood vessels, like the arteries that run next to the spine being injured. And both surgeries went very smoothly without complications. So, you know, this poor man was suffering and just miserable and crying. And I said, all right, let's give it a try. Let's give it a try since you've got nothing else but fusion. He didn't want fusion. He didn't want his thoracic fused. And by the way, there's probably nobody that would fuse him because most doctors don't believe in curing pain. They don't believe in surgery for pain because they don't believe the surgery works. But if it's done properly at the right levels, it will work. I've done it thousands of times where we've cured pain in the back with surgery. So I said, look, I can't make you any promises, but I'll try as long as I can do it safely. And here we are today doing it. So this really is historical day from the spine standpoint in the world. I truly believe this endoscopic surgery that I do, the Deuk Laser Disc Repair, will one day replace all spinal fusions, about 95% of them. There will be a few people who still need a spinal fusion, but 95% of them will be done away with. And these endoscopic procedures that I'm performing at Duke Spine Institute will replace them. So this is just another step, another milestone, so to speak, another waypoint in this journey with endoscopic spine surgery. So no, we don't commonly do thoracic, but now I'm open to it. I haven't done mid-thoracic. I've only done T10 and down. And there's something about T10 that's unique, T10, 11, 12. That's where you start getting into the floating ribs. So the ribs are not fixed in the front. They're floating, and so it makes it, I don't know if it makes a difference, but also the vertebrae are bigger, and so it spreads things out a little bit more and makes it easier to gain access to the disc space through a transforaminal approach. Now, is there any other surgeon in the world that does endoscopic thoracic surgery for disc herniation? There is. There's a pioneer named Dr. Curtis Dickman at the Barrow Neurological Institute. He's the only one in the world I know that does endoscopic thoracic surgery, but he does it through the chest. Basically, you go to the hospital and he has a anesthesiologist puts a double lumen endotracheal tube and they suck down one of the lungs and collapse one of the lungs. He has a heart surgeon helping him, and it's a big, big deal. And they go through the side. They don't go through the back. So it's a lot more risky than just going through the back like I'm doing. So this is a better procedure than what Dr. Dickman does, or did. I think he still does them. It's safer, it's faster recovery, there's no hospital stay involved. Nobody wants to go to the hospitals today because of infected patients with COVID-19 are there at the hospitals, unfortunately, getting treated, and the risk of infection is just much higher in the hospital. This is the annular tear that I've been working on. You can see there's some calcification of it. It's turning golden color with the laser. The laser, by the way, folks, is that little white fiber, the clear fiber, not white, but clear. And it has a blue part to it. And then the blue is just a plastic covering. And then that peels off at the end, and you have just a laser. It's a piece of glass, basically. It transmits laser energy in pulses. The pulses are very fast. And I think we're at, what, 20? So it's 20 pulses per second. Oh, no, 20 pulses per minute, right? 10 pulses, sorry, 10 pulses per second. And so anyway, that's a lot of very fast pulsing. But each pulse delivers a specified amount of energy that we tell the laser computer how much energy to deliver with each pulse. And it does. We're just about done. Yeah, he's not happy about this. I can feel him moving a little bit. This is going to be the most painful part of this herniation right here. So overall, I feel pretty good about this particular disc. This is the T10-L1 disc. This is the lowest of the three we're fixing today. And all of his discs turned out to be 10 out of 10 pain on the discogram. We didn't know they were going to be 10 out of 10 pain. All I knew is that we had done everything else except treat the discs. And I knew that they were herniated based on the MRI scans that he's had. So this was really his only hope of getting out of pain. I don't know if it's going to work yet, but I believe it will. We'll know soon enough in recovery. God willing, it'll work for him. Thank you for asking, Sue. It's always a pleasure. One thing unique about this surgery is I did have to do 3 separate approaches through the skin. So I had to do 3 separate incisions. I'm going to have to do 3 separate incisions. So normally in the lumbar spine I can get all 3 discs treated with 1 incision in the skin. Same thing with the cervical. But I didn't want to take any chances, so I just did 3 separate incisions. Or I'm going to. I haven't done them yet, but I'm about to. All right, just about done here. And there it is. Done. Yeah, he's not happy about that. But this is the most painful part of the herniation right here. You can see the disc right there where the herniation was. It's gone. Stand by. Let me turn this off. Let go. Let go. You have to turn the irrigation off. Let me have the middle thing, the dilator, to suck it out. So 1 down, 2 more to go. I'm sorry? Thanks. I'm not sure what you said, but I'm sure you're doing something good down there. All right, so that's 1. Let me have, come on, I need my roll. Watch that needle there. But you're watching history. Never before, ever, has anyone done this surgery. This is a transforaminal thoracic disc repair, discectomy, however you want to call it. No one has ever gone transforaminal in the thoracic spine before. I know that for sure. I know all the players who do endoscopic surgery around the world, in China, Korea, United States, Europe, everywhere. And nobody does thoracic disc herniations transforaminally. I told you Dr. Curtis Dickman is the only spine surgeon. He's a neurosurgeon and at one of the top neurosurgery programs in the world, if not the top, in the Barrow Neurological Institute in Phoenix, Arizona. And he does transthoracic. He doesn't do transforaminal. He goes through the thoracic cavity, in between the ribs, and pokes in and drops the lung, and then goes retroperitoneal, I think, or transthoracic. I'm not sure if he goes retroperitoneal or transthoracic, but he basically probably goes transthoracic because he drops the lung. And again, it's a much more dangerous surgery, much more bloody, much more painful. This patient will go home, God willing, in an hour after his surgery. I expect him to go home, so there will be no hospital stay. All right, we're going to move on to the second disc. This will be the 11-12, T11, T12 disc herniation. Once again, the hardest part was in the beginning, where I had to gain access to the disc through a lateral approach, posterolateral approach, and that's the hardest part of the surgery in my opinion. All right, tell me when we're there. Is that it? All right. So let's see if we can, yeah, your ribs are not so far apart this time. It's actually pretty good. And the wag angle is not bad either. We're close. You're a little bit off. So did you move it? All right. That's definitely not better. That's worse. So once again, you're watching history because no one has ever done this. I've done 2 single levels. I think I did a 12-1 before and an 11-12. I've never done a 10-11. I've never done 3 in one surgery. So Yeah, what can I tell you? How's he doing?
Pressure is 96.
Yeah, I'm fine with that. Are you ready? Yeah, I think that looks decent. I think we can do a little bit better, but I think it's fine. I think it's fine. Because we're not actually placing anything. We've already gone. We already have our guide wire shot. I can't tell shot. All right, it looks like the guide wire came out, which is good. Came out of the tip of the needle inside the disc. Shot. Let's make sure it's staying there. Yes, it is. Shot. Looking good. Our needle is out of the disc, out of the foramen. Guide wire is still there. Most important thing is to keep the guide wire locked in position. Don't let it move out or in at all. You don't want your guide wire moving. So now we got just the guide wire. You already got a shot? Yep, perfect. Are we okay, guys? All right, we're making our second incision. This will be a 4mm incision once again. 4 millimeters is pretty tiny, and the whole purpose of it is to put, can you see this, Sonny?
Yes, sir.
Is to fit the dilator, and then over the dilator goes a tube. I do the whole surgery through this tube. Can you guys see this tube?
Yes, we can.
Yeah, I'm repairing this thoracic disc herniations with a tube that's like a coffee straw made out of metal. Of course, it doesn't cost the same as a coffee straw. It's over $1,000 for this tube, but it's worth it. You know, it's good quality product, well designed. All right, so we're going to bring the dilator down once again. We're going to go through that 4mm incision. Shot. I'm going to use X-ray to guide myself. While I'm doing this, I'm checking the movement of the dilator down the guide wire. I'm also checking the guide wire to make sure the guide wire doesn't move in or out. That would be bad. Shot. I'd have to start over again and start placing the guide wire so it's not moving. If it goes forward, it's going to poke into the thoracic cavity, which you don't want. If it comes out, then you've lost all control of your safe path, your safe corridor, right? So it's important to make sure your guide wire doesn't move while you're manipulating it and putting instruments over it. So there we go. The tip of the dilator is right up against the herniation. I can actually see it. It's right there in front of the dilator tip. Now, there it is, right on the herniation. Okay? He doesn't like it. Give me an AP. He's moving. Why is he moving? Because he's feeling discomfort. That herniation hurts. That herniation is the source of his pain. So he's trying to get away from me. All right. Let's go back to lateral. Just lay still. Okay, he's a little more awake right now, which is fine. As long as he cooperates, doesn't like try to get off the table, it's okay if he's, you know, the anesthesiologist, as I've said before, is always trying to, yeah, so he's not going to tolerate me going in right now. So I do need him. Yep, no problem. Take your time. So the anesthesiologist is always juggling between putting the patient too much asleep or keeping them too much awake. And it's a hard job. It's probably as hard as what I do, easily as hard as what I do. And to do it just perfect is difficult. So if you oversedate the patient, they stop breathing, you can lose their airway, they can die, they can aspirate, all kinds of bad things happen. So you really want to have an anesthesiologist that does it just perfect so that the patient's not oversedated, not aspirating, but that they're saturating well and breathing well, protecting their airway, or the anesthesiologist is protecting their airway. Let me know when I can move forward. You don't want them too awake, otherwise they just remember that they were in pain and they don't like you very much. I'm proceeding. Thank you. All right, so we're going to push through the herniation right now, and this is one of the things about the Deuk Laser Disc Repair technique is that it actually pushes the herniation back into the disc space. Why not? And by doing that, it makes it safer to remove the actual Shot, herniation. Why is the scope on? I guess it needs to stay on, or we just don't have the light source on, right? Shot?
Correct.
That's fine. All right. So I put the tip of the dilator into the disc space. I'm going to hold this, take the guide wire out, and I'm going to advance this this dilator a little bit more. Shot. To where it's inside the disc for sure. Then I'm going to bring in my tubular retractor. Remember, we're doing the whole surgery. The whole spine surgery is being done through this 4 millimeter outer diameter tube. It's remarkable. I could tell you the kind of surgeries this patient would have as an alternative would be a fusion with an incision this big from my finger to finger on his back, and screws and rods all through here. Very, very painful recovery. Very painful recovery. In the hospital, probably the ICU. In the hospital for days. Now, I do thoracic fusions as well here at the surgery center, outpatient. But most surgeons wouldn't be able to do that. They'd have to do it in the hospital. Shot? So this patient is really having the most advanced spine surgery in the world. His alternative, the only other thing that would help him would be, I hate to say it, probably a thoracic discectomy combined with a fusion. So you're talking about a surgery that would normally cost in the States $500,000 easy. With the hospital stay in the ICU and everything, all the surgeons, thoracic surgeons being involved. 2 spine surgeries, one for the anterior approach to remove the disc and reconstruct the anterior middle column, and then a second surgery through the back to put in screws, rods. They would put in plates as well. So this surgery is replacing a very invasive shot. Is that your shot? Right there?
Yes, sir.
It's replacing a highly invasive open thoracic fusion surgery as the only alternative this patient would have. And even then, most surgeons wouldn't do it for a herniated disc. They wouldn't. They just let the patient live in pain the rest of his life. So at Duke Spine Institute, we don't believe in making people live in pain and suffer in pain the rest of their life. We want to get rid of their pain so they can have a good quality of life. And that's what this patient wanted. He wanted to basically to get out of pain so he could have a quality of life. He's a professional musician, and he, let's get the fluoro out. And he actually plays the guitar, and I think he actually plays and teaches special needs children. That's what he does. So I think he's in my opinion, he said I'm his hero, but I think he's my hero, actually, for what he does to help people. He's my hero. People like him are my hero. So honestly, it's an honor and a privilege for me to be able to help somebody like him out. All right, let's see here. I just hope this works for him. So we're getting ready to start the Deuk Laser Disc Repair on the second disc. This is the T11-12 herniation. The last one we'll do is the T10-L1. And once again, we're using the cervical scope, which is a 4 millimeter wide scope rather than the lumbar scope. All right, let me see here. What I'd like to do, I want to maybe move my irrigation line to the other side of the scope because it's kind of interfering right here. So hold on a second. Let's see what we can do. Switch it. Yep. And go ahead and hold this over. You guys ready? All right, good. All right, so let's do this. I've got my 2 amazing assistants here, Luis and Sam. Sam I Am. Do you know who Sam I Am is? Do you know? So you're from Alexandria, Egypt. This is, they had the greatest library in the world. And there's, Sam I Am comes from a book. Do you know what book it comes from? You don't. Have you heard of Dr. Seuss?
Yeah.
It's from Dr. Seuss. Huh?
I never read the stories.
You never read Dr. Seuss's stories? Oh, Sam, you have to. That's your homework for tonight. Okay? When you go home and you relax, you go look up Sam I Am, Dr. Seuss, okay?
Yep.
And start reading, because those books are special. Very special. Anybody know Dr. Seuss's real name? Let's see if our audience can give us Dr. Seuss's real name without cheating and looking it up on Google or Yahoo, some other search engine. Anybody know? Huh? Where is he from? I don't know where he's originally from, but I know where he settled down. Lake Arrowhead. So somebody says he's from Lake Arrowhead, possible. His name is Giselle. Giselle. How do I know this? Because I went to UC San Diego for my undergrad, and we renamed the library after him, his real name, Giselle, the Giselle Library. And they have his entire collection was donated by him, because he lives in San Diego, or lived in San Diego. I don't know if he passed away. But you could go down to the bottom floor of the Giselle Library, and you could actually look at all of his old books and his sketchings and drawings. It's throughout the entire library. It's quite amazing. But I also read Dr. Seuss, obviously, as a kid. It was read to me, and I read it myself, and his stories are pretty wonderful. Good for children. All right, so we're inside the herniation, inside the annular tear, and we're at the T11-12 level, okay? And we're basically debriding the annular tear. That's what we're doing. Debriding the annular tear that caused the disc herniation. So we're cleaning up the tear that has been inflamed for years, or since his accident, whenever it was. Please do. This is the cause of his thoracic pain right here, this tear. This tear has been trying to heal since his accident, since he had it, and it hasn't been able to successfully heal because there's jelly, nucleus pulposus, stuck in the middle of it. And that jelly causes inflammation. So you've got this tear in the annulus that wants to heal but can't heal because there's nuclear material wedged in. That is called the interposed nuclear herniation, interposed herniation for short. So if you talk to me about interposed herniations, and you all should understand what it is, it's basically the nucleus pulposus that's stuck between the torn sides of the annulus, just wedged in there, keeping the annulus from healing. So whenever people get a herniated disc, they first have an annular tear. And that annular tear wants to heal, and when it does heal properly, there's no pain. There's no back pain, no leg pain, no nothing. But if the tear doesn't heal properly, you get chronic back pain, chronic neck pain, or in this case, chronic thoracic pain. So people who cannot heal their tear properly, there's a piece of herniation. People who cannot heal their tear properly, there's a piece. See it coming out? Yeah, baby. Get out of there. That's a piece of nuclear herniation that was wedged in the annular tear. If you can't heal your tear properly, you're just going to keep having pain. The pain you're having is inflammatory pain. Inflammation pain hurts. If you've ever had a zit on your face or anywhere on your body, you know there's a piece of herniation. You know how painful inflammation can be. Now, a zit is inflammation from a bacterial infection. Infections cause inflammation, but infections are not the only cause of inflammation. Inflammation can be caused by your own body attacking itself. Inflammation can be caused by viruses. It can be caused by bacteria. It can be caused by fungi. It can be caused by protozoans. It can be caused by non-infectious causes like foreign bodies. And it can be caused, most importantly, for the spine, it's caused by the nucleus pulposus being out of place, being somewhere it's not supposed to be, right? Does bacteria living on your skin cause inflammation? Dr. Sakar? No, I said living on your skin. No, living on the skin. Does it cause inflammation? No. But bacteria somewhere it's not supposed to be under your skin will cause inflammation. Well, the nucleus pulposus normally doesn't cause inflammation. There's a piece of herniation. Stand by. But when the nucleus pulposus squeezes out through the annular tear, that's what causes inflammation. That concept was discovered and first described at Duke Spine Institute. Now, there is another neuropathologist who also discovered it and took pictures of it. He discovered inflammation in the disc within the annulus, but he didn't know, I don't think he knew that the nucleus was the cause. Either way, it's an important concept that 99% of spine surgeons don't know. Therefore, they're not going to be able to fix your pain when it's coming from a herniated disc or inflammation. There's another piece of herniation. We're going to get that out. Hopefully get it out. These are not big pieces. They just look big because we're in a very small space and we're magnified. Let's see if I got it. A lot of times you have to zap them with the laser a little bit, you know, to come out because they're just so big and stuck down. We have any more questions, Sonny?
No, sir.
All right. Yeah. You can see how stuck down this piece of herniation is. It's not wiggling free like I want it to. It's taken a long time of zapping it with the laser. You want to try to free them up so you can pull them out. It kind of started coming out and then it just stopped. Normally they just keep coming when they start coming out. All right, let's see if I can grab it. So it's definitely stuck down, and why is it stuck down? It's because of scar tissue, because of chronic inflammation. What does scar tissue do? Well, think about it. If you cut your skin, it's scar tissue that holds your skin edges together and causes them to stick together and heal. So scar tissue acts like super glue in a way. It adheres things to each other. It sticks things to each other. In this case, there we go. Come on out. It sticks the herniation down to the annular tear, annulus fibrosus. That's what I'm freeing up. I'm using the laser to free the herniations off of the annulus fibrosus. Basically, it's an annular debridement. It's a debridement of the annulus right where the tear is. Trying to get these loose fragments or stuck down fragments of nucleus pulposus out of there, because they're the cause of the inflammation and pain. All right, so I am halfway done with this one, and then we got one more to go, doctor. So I would say we'll be closed in at most 30 minutes, maybe 25 if we're lucky. "25 minutes to 30 minutes. I'll be done in 20, 25, and then we'll bandage. We have to close up the incision. I'm withdrawing the tube, pulling it backwards. As I do that, I get closer to the outer part of the annulus. right where the nerves are. So I'm actually removing the herniation from the inside out. That was a technique taught to me by Dr. Anthony Young, one of the pioneers of endoscopic spine surgery himself. When I trained with him. He didn't teach me thoracics or cervical surgery, endoscopic surgery. He taught me lumbar. He's never done cervicals or thoracics. I think he did them once or twice, he told me, and he had some bad outcomes. I don't want to say anything negative, but he said he didn't feel he could do it safely, so he never pursued it. He just stuck with lumbar. Became one of the most famous lumbar endoscopic surgeons in the world. I know he's still alive, and he's going to China now and teaching the Chinese how to do endoscopic spine surgery. Because, of course, he is Chinese, and he wants to train the Chinese spine surgeon, so he spends a lot of time in China. I'm just thankful he taught me. He gets to pick and choose who he wants to teach. He doesn't have to teach anybody. I was very fortunate that he was willing to teach me, because he turns a lot of people away. I know that for sure. Of course, he taught his own son, Chris. You talk about a man who bucked the system. Oh boy, did he buck the system. A true pioneer. When everyone else was just doing fusions and fusions and fusions and open back surgery, he was one of the few in the world to ever do endoscopic surgery. And of course, there were a lot of surgeons who didn't like him because he was a pioneer, a visionary. You know, you think pioneers and visionaries have the gratitude of all their colleagues, but they don't. They usually have the scorn, because they're doing something special, unique, better, and their colleagues aren't happy about it. They don't want to call people, neurosurgeons, spine surgeons don't want to believe that they're second best to anyone. But it's a reality. Sorry, if you're not doing the most advanced technique in the world, then you are second best. And you know, the people that practiced around Dr. Young in Arizona, especially the Barrow Neurological Institute, he had the worst. He had a top neurosurgery program for spine surgery. Curtis Dickman, Volkner Sontag. And when they started seeing what he was doing, they were freaking out. And they tried to put him out of business. So that's the reality of being in spine care and neurosurgery. Your colleagues that should be supporting you and helping you to make progress, they are usually against you, either secretly or openly, trying to harm what you're doing and stop you from succeeding, doing things better than them. And of course, there's a few people who don't see it that way, who want to teach others about their technique because they want to help other patients around the world that they can't reach directly themselves. This is what I'm doing with this right now. We're broadcasting these surgeries live from Duke Spine Institute because I want to teach other surgeons what the possibilities are to help their patients and have great outcomes, better outcomes than they're having now. But you'd think they'd be banging my doors down. They don't. They all don't want to believe that someone else has figured something good out and that they don't know what it is. Your ego has to take a big hit in that situation. And most surgeons don't like their egos hurt. Just about done here. This is all disc material. You can see the tear of the annulus right there. Okay. The cable went in too far.
What's the maximum amount of disc you can remove by this technique there?
What's the maximum? So we have a question from our anesthesiologist. What's the maximum amount of disc you can remove from this technique? So we could take the whole disc out if we wanted to, but we don't want to. We want to just take out the part that's causing the pain, the herniation basically. Stand by. So typically we take out 5%. The herniated material, the annular tear, the part that we're removing is typically 5% of the total disc volume. That's normal total disc volume.
You don't have to replace it with something, it doesn't make the disc unstable.
You don't have to replace it with something is the question. No, you don't. It doesn't make the disc unstable. So instability is defined as pain or neurological deficit. That was the original definition of instability. And the patients that have this surgery don't have pain and they don't have neurological deficits. We either fix their deficit or they didn't have one to begin with. So we're not creating instability with the surgery because we're not creating any new pain and we're not creating a neurological deficit. Does that make sense? Now, could you argue that there could be some structural instability? You could argue that, but there is none. The patient already has scoliosis. They already have listhesis. So, you know, the instabilities of moving bones is already present. But it's not truly instability if it's not causing pain or neurological deficits. And by the time we're done with this surgery, this patient will still have scoliosis because I'm not fixing their scoliosis. They'll still have listhesis because I'm not fixing their listhesis. But they don't have instability because they don't have pain or neurological deficit. You see how that works?
Does it increase the load on the facet?
Does it increase the load on the facet? I think whenever you have a disc injury, it does increase the load on the facet. But the disc injury is what would increase the load on the facet, not the surgery.
Not removing the disc will not...
I'm not removing the disc.
No, you are removing part of it.
I'm removing the herniation. The herniation was already removed, not by the patient's trauma. The herniation is not part of the disc. You do know that, right?
It's a broken part of the disc.
Well, it's broken and it's outside the disc. You understand? The normal confines of the disc follow the border of the vertebral body.
Yeah,
And
anterior and posterior longitudinal.
not really. Most
Anterior.
most herniations stay underneath the posterior ligament. So they haven't gone past it, but they push it backwards. They just don't go through it. But when you get past the shape of the vertebral body, which is a concave shape in the back of the disc, once you change that configuration of the disc, you have a herniation. So anytime you have a herniation, the disc material is pushed out of the annulus fibrosus and the tear within the annulus. Does that make sense? In other words, we're not removing any disc material at all. We're just taking the part that removed itself out. Because where it is inside the annular tear is causing all the symptoms. That would be like saying if you have a bullet in your body, someone shoots you, and you have a bullet. If I go take your bullet out of your liver, am I removing the liver? No. I'm not removing the liver. The bullet already removed the liver. The part of the liver it was going to remove. I'm removing the bullet. I'm removing the foreign body that doesn't belong there. Does that make sense? The nucleus pulposus doesn't belong within the annulus fibrosus. It belongs contained inside the annulus. It doesn't belong within the annular tear. So I'm not actually removing anything that's normally there. I'm removing something that was already sticking out that shouldn't be sticking out. So we're not removing any of the disc, we're just removing the herniation, which is already displaced.
You mean you're simply removing the nucleus pulposus?
Yeah, and I'm cleaning up the annular tear. My surgery is unique in that it's the only surgery in the world that cleans the annular tear, debrides it. It's called a debridement. No one else does that. Everyone else removes the herniation, the herniated nucleus pulposus.
You remove the entire nucleus pulposus?
No, no, no. We only remove the piece that's sticking out through the annulus, only the herniated part, basically. Does that make sense? And there's a lot of debate out there about how much nucleus should be taken out during a discectomy, for example. But we don't take any of the normal nucleus out. I'm only removing the part that's herniated.
Then why do they say that after 40 the nucleus pulposus is absent?
Absent?
Yeah?
No. Who told you that? It's not true.
Okay.
No.
I mean it dries up or something.
No, it doesn't. No, it's not true. If you have, I have 85-year-olds with normal discs. Normal. Perfectly normal.
Nucleus pulposus.
All the nucleus they had when they were born or when they were 15, whatever. And I have 15-year-olds that have no nucleus left at some discs because they have disc injuries, even at a young age. Who knows, maybe when they were 5, 6 they fell or something and they injured their disc. The only way to lose your nucleus pulposus is with an annular tear. And the only way to get an annular tear is through trauma. You understand? Trauma. Fine. All disc injuries start with an annular tear. All disc injuries. 100% start with an annular tear. That's something most people don't know. It's something that most people don't think about.
Is the tear radial or circular?
Well, the tear is through and through, from the center to the end
So it's
of the annulus.
radial.
It's a radial tear. It could be broad-based, but in the end, it's a radial tear. All right, we're almost done here. Why am I feeling wetness on my foot again? This is the outer part of the annular tear right here. You can see it's been collagenized or scarred from chronic inflammation. Just about done with this one.
Can you see the nucleus pulposus from the annulus here?
This is the tear and it has nucleus material stuck in it.
This is the nuclear material.
This is the annulus right here.
Yeah, this is
Right what I'm working on right now. Annulus.
I mean the dark part.
The dark part is a hole. It's just a hole. You can see the crisscross fibers of the annulus. They're white. Right here. We're just outside the annulus right now. This is the end of the disc. The outermost part of the disc we're looking at. You can see the fibers crisscrossing. You see it? The dark part is where the herniation and tear were. This stuff looks good.
Do you see the lamellar pattern of the annulus?
There's the epidural fat. You see that? Right outside the disc. And the spinal cord will be just in there, over there. Okay? Beautiful. The spinal cord will be at 12 o'clock, but we didn't see it, which I don't want to see it. I'm perfectly happy not to see the spinal cord. All right, one more to go and we'll be done. Move all this over. Is our next patient here ready to go? Hold pressure here. Yep. Let's get the, no you can't, no, you're too close to the fluoro. You cannot ever get that close to the fluoro, ever. You have to maintain 6 inches from that. That's the most important thing. You don't want to contaminate the fluoro. All right. Go ahead and swing the fluoro around. You got to pay attention, Sam. There's no pressure on the arms, right, with the fluoro? When you're ready, take your lateral shot. All right, one more disc to go. So that's a good shot right there. Shot. I want to get this guide wire out the end. I think I just did that shot. Yeah. So the guide wire is out in the disc. I can take the needle out. Perfect. By the way, the next surgery will be a more typical surgery. It's a patient with a herniated disc at L5-S1. They've got back and leg pain. So it's a single level. Should be quick. How is he doing? He seems to be responding a little bit shot.
Yeah, he's responding now, so
Shot. Seems a little tight. Where's the knife? Do not take my knife away until I am done. Put it here. Shot. How's he doing? Shot? That's good. I'm okay with that. The lower you can keep it, the better. Shot? All right, so we're on the next disc. We're ready to advance into the disc space. We're literally with the tip of the dilator at the back of the disc of T10-L1. Shot. Take. Take. Again, there's a tear here, so this patient, the tool is going into the disc easily because of the tear. The tear happened in the annulus during the trauma, during the motor vehicle accident, probably. I don't think he ever had any problems before his car accident. Of course, his car insurance wants to deny paying for his medical care, saying it's not related, but that's, in the United States, that's what they typically do. At least 90% of the time, they don't want to pay, so they just deny it. Shot? They deny responsibility. I'm sure he's going to have to get a lawyer involved. But he just wanted his back fixed. And shot? Yep. Go ahead and put it there. Shot? So as I'm advancing my tubular retractor, I'm looking at the dilator. Take it. We're done. We're in good position. All right, fluoro out. A little bit overexposed on the fluoro. Hey, watch it. Watch it. It's going to break if you're not careful. This is our last level. Isn't that amazing? 3 thoracic disc herniation, 3 4mm incisions, blood loss of 3 cc's max. It's incredible. You guys are seeing for the first time ever done in the world. There's good and bad, right? No one wants to be doing the first, but someone's got to do it. And since it hasn't been done and it's necessary, we're doing it. All right. That's the confidence I have in my team. I wouldn't do this unless I had trust and faith in my team. My anesthesiologist, my team, my staff. There's a piece of herniation. I would never do this at the hospital. I don't trust the hospital staff. Besides, the hospital doesn't have the equipment to do it. Stand by. The hospital has never invested in endoscopic spine equipment. It's a big investment. It's over $1 million to set up an operating room. Actually, probably closer to $2 million to set an operating room up with all the right equipment. To do it right. That's what we did here at Deuk Spine Institute. We invested millions of dollars to have a state-of-the-art operating room for this type of spine surgery. That's why these surgeries are done here, because they're safer here. They can be done outpatient, and we have all the right equipment and staff to do them. The hospital doesn't. Hospitals don't have everything. You think they'd have everything you need to do more advanced surgeries, but most of them don't. A lot of hospitals, believe it or not, they don't have the money to invest, so they don't do it. Even though the surgeon requests it, they won't do it. The hospital that I was doing most of my surgeries at was in Titusville Parish Medical Center, and I went to them years ago and asked them to invest in this technology. This was 15 years ago, and they refused. They said, we don't have the money to do it. And I said, well, I have a choice. I either don't pursue this technology, which I felt was the most advanced spine technology in the world, because I had seen the Koreans do some, I'd seen Dr. Young do some, and I had to make a decision. Do I either just let it go and let the fact that the hospital doesn't want to spend the money on this equipment determine how I treat my patients, or do I want to pursue it and take a loan out myself and buy the equipment? And that's what I ended up doing. I ended up borrowing millions of dollars, and basically,
That's an act of extreme confidence.
yeah, it's an act of faith,
Yeah.
right?
Yeah.
And confidence. I was confident in the procedure working. And obviously, when I started, I bought as few pieces of equipment as I could, right? So I kept my capital investment minimal just to make sure that it was really going to work. And once I saw the results reproducible time after time with elimination of pain, I knew we had something very special. And that's when I started buying more equipment and expanding. We only bought our laser this year, right? 2020, was it, Luis? We've been borrowing a laser all these years because it's too expensive to buy. And now we actually can afford the laser. So we decided to have a laser, because the problem was the company that provides the laser, you have to coordinate with them. And if they're not available on the day you want to use the laser, then you have to cancel your surgery. So if I have a patient coming from out of town and they want their surgery on a Thursday and the laser company doesn't have the laser available Thursday, well, now I can't take care of my patient the way they want to be cared for. So, having your own laser, it's a convenience thing. Really, mostly convenient for the patient. I could have put my children through college with the money I spent just on the laser. Oh yeah, medical devices are so expensive. 5 minutes.
Okay, like that.
So again, I'm just working my way out of the disc, and I'm debriding the tear. The place where the laser fiber is, the 12 o'clock position, is medial. It's towards the spinal cord, towards the middle of the disc, and that's the tear right there. You can see the end plates right over here. Now what you're seeing at 6 o'clock is the lateral part of the herniation, sort of the side of the disc. Oh yeah, look at the pieces of herniation coming out there. There's two reasons they're moving out now. They're moving out because A, we're here and we're disrupting their attachments because they have attachments. They're scarred in from all that inflammation that's been going on. They're scarred in, and I'm releasing those attachments with laser energy. And they're jiggling around and moving because of the pulse wave from the laser. It's a pressure wave, and it kind of blasts them. It gives them a mechanical energy. So the laser provides thermal energy, and it provides mechanical energy to the surfaces it's treating. This is not the kind of laser that you just put on the skin and it works. None of those lasers work for fixing disc herniations. There's a lot of phonies out there. Doctors are saying that they can do laser surgery on your back pain, and they put the laser on your skin. And that doesn't really do anything at all for these herniated discs. So that kind of technology doesn't work. Just about done. Sonny, any questions from our audience?
No, sir, just praises.
Well, save the praise if this works. I hope and pray that it does for this patient, because he's got nothing else. Nothing else but a life of misery and suffering to look forward to. So that's why I'm doing this surgery. I'm doing it because I don't want him to be condemned to have to suffer the rest of his life and basically be depressed and anxious all the time and not be able to take care of other people and do what he does. We're all interconnected, each one of us, in one way. Right? 7 degrees of separation. Isn't that what they say? 7 degrees. I believe it. All right. Just about done. Another 2 minutes and we'll be finished. And we've got 3 little incisions to close up, which will be really quick, right, Luis? And then we'll get this patient back to recovery. And hopefully, if he's willing, we can do an interview of him in the recovery room and see how he's doing. He'll probably be ready to go in about 30 minutes to an hour. Most Deuk Laser Disc Repair patients are ready to be discharged home, usually within 30 minutes to an hour. I don't see why he wouldn't be able to be. We'll see how he's doing. We're just at the outside of the herniation of the disc. There's not much more to do. Just a few more seconds. This is all that collagenized area I was talking about earlier. We're kind of working our way outside the annulus here. This is all the tear and scar tissue from chronic inflammation right there that the laser is working on. We're starting to get to the thin connective tissue on the outside of the annulus. And there we go. There's the epidural fat right there. We're outside the herniation, outside the disc, right here. And it looks good. Have some fat We're done. All right, so Sonny, why don't you show our audience here these three. Let's go ahead and focus in here.
Yep, I'm there.
All right, just here for a second. So we did the whole surgery with a scope. Watch it. And the scope, can you see it?
Yes, sir.
Camera, there's the scope here. Once we remove the camera, you can kind of get a better idea of how this works. There's a little lens here, lens down here. This is a fiber optic scope. It's got, I think, 5,000 fiber optic fibers packaged in there. And it's got some tubes where we can do some work in. But you can see the laser fiber here goes into the end of it. You also have a light fiber here that brings in illumination, basically light, very powerful light, fiber optic light. Goes in and then it projects out the end, and then you got your irrigation ports. So that's it right there. And then, of course, we went down and we did the whole surgery through this little tube. You can see the tube coming out. We did 3 holes because we had 3 separate discs. Okay, take it. Fluid adapter, you got it? All right, and we're just going to put pressure in case there's any venous bleeding. You're all done. You did great. How's he doing?
He's waking up, so put him down.
Stable? No, we're done. We're done. You can wake him up. All right, go ahead and type your questions for me. I'll come and answer them. But thank you, everybody. It went well. We were able to do everything I was hoping to do. I didn't expect to be able to do it, but I'm very happy that it worked. And hopefully it cured his back pain. We'll see. Go ahead and type up your questions, and I'll come and answer them for you in the conference room.
The pain level got to about an 8, a 9.
The right side of my body from the waist down was pretty much useless and in pain constantly.
The pain was chronic.
It was an aching, stabbing.
It became unbearable. It became where I didn't want to get out of bed. I didn't want to talk to anybody. I didn't want to do anything.
I had the pain every single day in my low back.
It's torturous. I can't go to sleep at night. I can't lay down. I can't sit for too long. Can't stand for too long.
I couldn't sit. I couldn't stand. I couldn't walk more than 50 feet.
It's excruciating.
Sends excruciating pain across my back. Gets down to my hands where my hands are numb.
I had no life.
If you are suffering from neck or back pain, the Deuk Spine Institute can give you the relief you need to live your life without pain.
Now I have absolutely no pain.
Not even 24 hours after the surgery was complete, I was able to be how I felt is normal. And it was good.
No scars, didn't hurt at all. As you know, when I woke up, it was totally painless.
The next morning, I was up and about and out, dressed on the job.
I have no pain. I'm living my life and doing great things, and I'm just very happy.
It's a great feeling not to be in pain.
Deuk Spine Institute has changed thousands of lives. Isn't it time you live your life pain-free? Log in to deukspine.com or call 1-800-FIX-MY-BACK for a free MRI review and consultation.
I feel like a new man again.
And it's thanks to Dr. Deuk. He gave me my life back.
Dr. Deuk did an amazing job fixing my back. I recommend him highly to anybody who has any kind of back issues, any kind of back pain. Don't wait. Go see him. The relief is amazing.
the pain
Okay, Dr. Deukmedjian, and we're wrapping up the first of its kind, and sad that we had so few viewers. Our social media platforms just suck, basically, and in terms of getting this out. So they're too busy getting out things about Black Lives Matters or, you know, Joe Biden because it's an election year, or WWE wrestling, that's important, you know. Anyway, long story short, we just made history in the spine world by performing a 3-level thoracic disc herniation Deuk Laser Disc Repair on a patient with chronic debilitating thoracic pain that had failed every conservative treatment we have that we could throw at them, and really had only 2 options: a fusion, which, you know, really would it work? Probably. But it's a major surgery to go through to get rid of thoracic pain from 3 disc herniations, because you'd have to fuse all 3 discs. So you're looking at at least a T10-L1, 11-12, 12-1 fusion with screws and rods. But instead, he decided to go with the most advanced technology, endoscopic spine surgery, the Deuk Laser Disc Repair. I went in and I basically accessed the 3 discs through a transforaminal approach on the left side. We got into each of those 3 discs with the endoscope. We found the tear, the herniated fragments. We removed them using a laser and grabbers. We call the grabbers pituitary rongeurs. And cleaned up the annular tear in each disc. And that's the source of the pain. Based on my experience, that's what I believe caused his pain. We actually tested each of the 3 discs with a discogram, and when I injected the dye, he had a reaction where he tightened up his back, and he said, yes, that's my pain, where I typically get it. We call it concordant pain, when the patient states that that pain that we've elicited with the discogram is their typical pain in that area, the quality of the pain, the location of the pain, maybe not the intensity of the pain, because we're actually injecting dye into the disc, so we're going to raise the intensity to super high levels, but what matters is that it's the right location, the right quality of pain. And so we confirmed that with the intraoperative discogram that we performed at each level while he was awake. It's called an evocative or provocative. It's 2 different names, mean the same thing, evocative or provocative discogram. Now, when I did the discogram, not only did I inject some contrast media so we could see on x-ray that we could see the outline of the disc herniation and the annular tear. We could see the herniation, the annular tear. Sometimes the dye goes in the epidural space. You could see the nerve roots and see how the relationship of the nerve root, how it's being affected by the herniation. And we did that. We also injected a little bit of blue dye in there. That blue is called indigo carmine blue. We use a 10% solution. That's my magic number. I'm giving away all my secrets. It's only because nobody's actually watching this. So really, who cares, right? We got more important things to watch, like riots on television and other garbage. But revolutionary spine surgery, first of its kind in the world, forget about it. It's not important. You know, curing back pain, not important. Next thing you know, curing cancer won't be important. It's just shocking that there isn't more interest in medicine and sciences, that the interest is in, you know, let's go watch some vines, some memes. Unfortunately, my kids are guilty of the same thing. So I take my kids' phones and computers away during the day just to make sure they go out. And I say, go out and do some swimming, go do some running, do some exercise, biking, go harass your sister. You know, I had to tell my son yesterday, we're going to have to go out dating. He said, why do I want to date? I got my computer and my video games. I said, that's the problem. When I was 15, we didn't play computer games instead of dating. Everyone wanted to date. I honestly believe video games are probably the answer to overpopulation of the world. These kids these days are so interested in video games and their phones that they don't even look at the opposite sex. And I'm not trying to be discriminatory here by any means, but I'm just saying, you know, they don't look at the opposite sex anymore. They're not interested in dating so much anymore. They're just interested in playing on their phones and computers. Right, Sonny? And so I honestly think we're going to see a drop in the world population as a result of digital technology. I guess that's one of the good things, right? Because we were overpopulating the world. Or at least we're on course for it. So maybe we'll see a drop in global warming too. Who knows? Anyway, getting back to the actual earth-shattering, groundbreaking, revolutionary, history-making surgery we just completed, in all honesty and seriousness, I'm very happy with the overall surgery. It went smooth. It went well. I did not expect it to go this well. I honestly thought 50-50 chance I'd have to abort at least one of the discs because I couldn't get access to it without putting the patient at high risk. We watched the lung fields the entire time. Whenever you're in the thoracic disc, spine, disc area, coming from a lateral approach, you got to worry about a pneumothorax. You got to worry about popping into the chest cavity and dropping a lung. So we were watching that the whole time. We didn't see that. The patient never complained about chest pain, never complained about shortness of breath. His saturations were perfect and stable. He was on nasal cannula the whole time, 2 liters. So I just got to say, I was very pleased. It went better than I ever thought it could. We actually got it done maybe even quicker than I thought. So I was very pleased. Let's just see how he does. We'll have an answer in about 30 minutes for you. Other than that, we've got a single level Deuk Laser Disc Repair, L5S1 herniation. A patient has back pain and leg pain on the left side. So this is probably something that millions of people around the world have. They live with it every day. It affects their quality of life. They can't walk properly. They can't exercise properly. They're hurting too much. They avoid activities as a result of the back pain and leg pain. So this surgery that we're going to do next applies to about probably 5 million people living right now around the world that have back pain or sciatica, maybe more than 5 million. Make it 50 million is probably more realistic with the back pain. 5 million with just sciatica. So anyway, the surgery you're going to watch next will be endoscopic surgery at L5S1 left approach. We'll see you then.